Hello, hello, everyone. How are you doing today? So it is me, Chris Tronson, here for another Wednesday edition of Ask the Experts. So as you will notice, I am solo. I'm solo today. Liz could not make it, so I apologize about that. I don't apologize. I don't know why I said that. I think I was apologizing on behalf of the people that were really, really excited to see Liz today. So that's what I meant. Not that Liz doesn't deserve some time off. So please don't hear it that way. It was more so for the people that really excited to see Liz. I'm always excited to see Liz. I'm always excited to work alongside her. So, but she will be back pretty shortly. So it's going to be me today. So I hope we have a good time. My goal today for Ask the Experts, and what it always is between Liz and I on Wednesdays, the first and third Wednesday of every month, and the fifth Wednesday if we have an extra Wednesday in the month. The goal is when you have OCD, I know right now there are a lot of providers that have wait lists. You might have just found out that you have OCD or a loved one has the disorder. And because of that, you want information. And I think this is such an important disorder to get information on because it isn't something that we hear consistently discussed. And when it is discussed, unfortunately, it's obviously discussed a lot of times incorrectly. So people saying they are so OCD or they have a little OCD. So here at the foundation, what we really want to make sure is that you feel like you have a place to be heard, to find a sense of community, to get your questions answered, and to get some clinical direction on what you should probably do next. So I'm Chris Tronson. I'm one of the IOCDF's lead advocates. I'm also a therapist in Costa Mesa, California. So I'm going to be answering these questions today from both a clinical lens, but also a lived experience lens, and just hope that I can get your questions asked and get you some direction that you'd like. So this has to be interactive for this to work. So make sure that whatever social media platform you are on, you are typing in those questions. They can be about anything. We did have a psychiatrist on in a recent one, and she was able to answer some medication questions. I think we got to all of them. But I can give you a little direction, but I'm not a psychiatrist, and we'll definitely bring a psychiatrist back on. But any other clinical questions, life questions you have, please, please, please go ahead and put them in the chat. So a couple quick announcements. First of all, always remember that this live stream is for educational purposes and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to find a trained clinician near you. So it's a good place. It's where my mom found my therapist all those years ago. So we were seeing a lot of talk therapists, ineffective therapists, therapists that just weren't helpful. And it was the IOCDF's resource directory at the time that found a clinician near me, and I was able to get treatment. So definitely want to go there. The IOCDF is not a crisis hotline. If you are in a crisis or you are feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention hotline at 800-273-8255. As always, we want to create a safe space, so be kind and respectful to everyone. At the end of the day, we are all here to support one another. A note that this is being broadcast on several social media platforms and it's being recorded. So those are kind of like the housekeeping. I have some exciting announcements at the end, but I want to just get those in the beginning. Also, as always, you can pre-submit a question. So if you go to iocdf.org/peace of mind, that's where we have people pre-submit questions. So I already have about 4 or 5 that were pre-submitted recently. And then we have a list of questions that have also been pre-submitted for a very long time. So I'm going to try to get to as many as I can today, as well as your live questions in the comments. So don't forget to put any questions or comments that you have in the chat, and you can interact with each other. The other thing I wanted to say is I always like to start when I'm solo because I don't have anyone to banter with except you all. What I like to do when I'm solo is bring up like a topic or a conversation piece to get us started. So the one thing I wanted to ask people to put in the chat and help everybody else is, how can you decipher that what you're going through is OCD? So what I mean by this is sometimes people will say, I don't know if that thought or feeling is OCD. What if it's true? What if it's real? I can't tell if something's OCD or not. So I'll get the conversation started. One of the ways you can tell something is OCD compared to just a normal, thought or feeling is that urgency. So what I mean by that is when you are experience intense urgency. So typically in life, unless it's a major thing, like you just found out that, somebody broke into your car or a family member was rushed to a hospital, most of the time things aren't urgent. There might be things you want to take care of or things that you want to handle, but rarely do we have it where it's like urgent, where we can't think of anything else, we can't focus on anything else, and we have to do whatever our mind is telling us. So for instance, in my own personal life, if I was exposed to some kind of cleaning chemical, I thought I had cancer. So I would immediately go and Google and look up research and try to figure it out. I would read the back of, the packaging. I would call the disease hotline or the whatever you call it, like when you get exposed, like the chemical hotline that was on the back, or I would get a doctor's appointment immediately. So that urgency is one of the ways that you can tell that something's OCD. So just to kind of get us chatting in the chat, what are some ways that you can decipher that something is OCD versus just a regular worry or concern? I see some hi. So first of all, hi, Dave Rubin. It's always good to see you. Hi, Gentile. That's amazing that you're from Brazil. Hi, Patricia. It's good to see you. Also, Nikki from Dublin, Chicago. Gentile says, my intrusive thoughts are ideas, not questions or pieces of doubt. So that's going to be our first question. So for example, you're going to kill that person. Does it still count as an OCD intrusive thought? Yes, absolutely. So that is definitely a definition of an intrusive thought. So sometimes it's not that you did something. It might be something more like this question that pops up in your head that says you're going to do something or you may do something. So a lot of people might wake up and have an intrusive thought like, today you're going to hurt somebody at work, or you want to hurt somebody at work, or let's say you are at Target and you are shopping for something, and OC might say to you, oh, you want to go in the kids section because you want to be around children, or you're going to hurt your children today. So it's not always like you're about to, or you did it in the past or far in the future. It might just be that day that you want to, that you're going to. So the way that I like to think about OCD is OCD wants to overprotect you, and it's gotten to a point that it's no longer helpful. So all of these intrusive thoughts, all of these obsessions, all of these compulsions are something that feel as if it is helping you and keeping you safe. So in this example, Gentile, obviously you as a person, you don't want to hurt someone, you don't want to kill someone. That's probably the very opposite of who you are as a person. And so OCD knows that that kind of experience or that thought, it is absolutely overwhelming and repulsive and something you don't want. So it's kind of tossing that question out, or that comment or statement in your case out, and wants you to kind of think about it and figure it out and make sure that this isn't something you want to do. So obviously nobody likes having that thought. And in this case, if you have that thought, immediately you want to defend yourself. I'm not going to kill anyone today. I'm not going to kill that person. I would never do that. That's not me. I'm a kind person. People like me. I don't even kill bugs. Like, there's all these different kind of defenses that we want to get. And what happens is it gets us very active. It gets us very worked up. And that's where OCD lives in the brain, that kind of fight or flight, that agitated state. So when you're busy arguing with OCD and checking to make sure that you won't kill someone, in your case, that's actually getting you out of like that logic rationale part of your brain and is getting you into that sort of freak out brain. So it's being able to identify, okay, this is an intrusive thought that OCD's provided for me, and my power is how am I going to choose to react to it and respond. So if I respond where I either, the four responses that people always make the mistake of for OCD, so this is for any OCD, so pay attention. The four is people will either freak out. So in this case, it might be, oh my God, I'm going to kill that person. That's what OCD says I'm going to do. Freak out, freak out. The reason that's not helpful is that's going to get you back into that reptilian part of your brain, that fight or flight, that freak out brain, and you are more likely to give into compulsions because you just want the feeling to go away. The second mistake people will do is they'll kind of debate or argue with it. So try to prove it wrong. I've never hurt someone. I never will hurt someone. I don't have a criminal record. The reason that that doesn't work is now you're having this back and forth argument with OCD. It's going to keep you in that kind of loop cycle, that compulsive rumination, and it's going to have you doubt yourself the more and more you debate and argue. OCD is never going to back down. And next thing you know, you're spending all this time arguing back and forth. It's going to start feeling more real, and then you're really going to question it. The third thing a lot of people try to do is avoid. So they might leave. Let's say you have that thought you're going to kill that person. They might leave the store or leave work. They might be overwhelmed by the thoughts. They take a nap or they distract themselves on their phone. And the reason avoidance doesn't work is because it's not going to go anywhere. In fact, you're teaching your brain that's something scary that I have to avoid. And the second your guard is down and you wake up from that nap or you have to go in that situation again, the OCD is going to hit you. Or lastly, what people will do is try to seek out certainty, reassurance, or get confirmation that they'd never hurt someone or kill someone in this case. So all of that is giving it too much attention. I always joke that OCD is like the Kardashians. They like any kind of attention whatsoever. They don't care who or where it's from. So if you're giving OCD all those attention in those 4 different ways, Gentile, what's going to happen is you're going to make it feel more real and it's going to start to overwhelm you and you're going to go into the compulsive cycle. So what we want to do in this case instead is notate that, okay, the OCD, or I just had a thought that I'm going to kill someone. My power is not to try to make that thought go away, but my power is choosing how I respond to that thought and that feeling. So it feels irresponsible to not do anything, but that's actually what I'm going to do. In fact, what I might do is go up to that person. Let's say it's at a Target, right? I might go up to that person, ask them the time, or start like small talk with them, or stand behind them in line when I'm, checking out to show myself like, look, I don't have to listen to these thoughts and feelings and be kind of imprisoned by them. So I'm going to choose to stand by this person and just see how it goes. And I'm going to lean into it and really practice that response prevention. So no compulsions and kind of closing up and things like that. So in kind of final, I know that was a little bit long-winded, but in final, it can definitely be those ideas. So you want to treat that as not as like a statement of truth that you have to freak out about. Really, really work on not treating that thought as if it's reality, because then you're going to get caught up and find yourself compulsing. And when we compulse, we become less clear because compulsions equal confusion. And next thing you know, you're really questioning if you're somebody that would kill or harm others. We have another question at 12:07 Skyless time. It's from Shipla Jane from YouTube. And it's, how do you do ERP for something which you avoided for 2 years? So really good question. And for everyone out there, the reason sometimes it can feel a lot heavier if it's been 2 years is because that's 2 years of reinforcing that this thing is scary. This thing is frightening. So let's say you have a more like emotional contamination to a room in your house. So let's say every time you go into that room, you just feel uncomfortable. Maybe you start to have a negative thought associated with that room. So you don't like to go in that room because that room always brings on negative thoughts and distress, right? So if you've avoided this room in your house for 2 years, every day that you wake up and avoid that room, you're basically telling yourself like, this room is scary. This room is terrible. I don't want to be in this room. This is bad, bad, bad news. So of course, if you just walk into that room, that's 2 years of reinforcement that this thing is dangerous. So for instance, we get taught as kids, right? Don't touch fire. Don't put your hands in the flame, because kids love to put their hands in like a birthday cake candles. So if you have spent your whole life learning that touching candles is bad, and then somebody's like, oh, I want you to just put your hand on this open flame, you're going to be so avoidant and recoil and freaked out. So what I would strongly suggest is, first of all, I always like to identify, why do I want to do this exposure? So let's say in my example I'm giving, because I don't have an example that you gave. So let's say that room for 2 years. I'm going to ask myself first, like, why do I want to do this? I want to get some motivation. I want to get my why. And what I would say is, okay, because I have stuff in that room that I haven't touched for 2 years, and all my stuff is stacked in the living room, and I want to spread it out into that room. It also serves as a guest room, and I haven't been inviting people over because I don't have a good excuse of why they can't go in my guest room. So it is really important for me to have entrance to that room. So you're kind of building that motivation and that why. Once you've done that, you can create your own hierarchy just around that thing you've avoided for 2 years. So in my example, it's like, okay, maybe I'm just going to stand next to the closed door. I'm going to stand next to the closed door for 30 minutes. Obviously, I wouldn't ask you to just stand and stare at the wall for 30 minutes. That'd be boring. But maybe I'm going to kind of like read a book, set up a chair, make some phone calls, and just really accept the fact that I am standing next to that door. And then the response prevention comes in, making sure I'm not ruminating, making sure that I'm not trying to reverse the feeling or clean or anything like that. And then I might work up to holding the door handle and then opening the door slightly and breathing in, opening the door fully and keeping that door open, just maybe for like 3, 4 days, and just having it open so the contamination crawls into the house. Sitting in the room for 30 minutes, sitting in the room for an hour, moving my stuff back in the room. So what I'm saying, Shipla, is like you could slowly start getting yourself back into that room. Or in your case, I'm not sure the thing you've been avoiding, maybe you could put that in the chat. And you can work up over time. And by teaching yourself, because remember, OCD treatment is a learning tool. It's something that you learn. It's something that it teaches you. The treatment is teaching you that this is not something that you have to avoid and be scared of. Over time, what will start to happen is that room will become comfortable. And then when you kind of make it your norm, you have stuff in that room, you go in that room, you just kind of live in that room, then what ends up happening is over time, that room no longer bothers you. So if you want to put in the chat specifically what you've been avoiding, I can give you a little bit more direct, but I hope what you heard from that is finding your why, working up a hierarchy, moving towards it, living in kind of like those values and goals versus the fear, and then making it your new normal. Hi, Grace from Michigan and Rachel from Manchester. We also, oops, I went too high up. So, sorry, when I go to the question, it like brought me back to the bottom. So I was saying hi to, I'm going to butcher the name, Ayelet from Israel, pretty name. We have Raul from India. All right, we have a question at 12:10 from Grace Manier. What are some good books or workbooks that people recommend for OCD recovery? I have the OCD workbook by Bruce Hyman. It's super helpful, that I recommended, but wonder if anyone else has recommendations or some books written by people with OCD or about OCD. So first and foremost, what I'd suggest is in the chat, if there is a book that you absolutely love, please put it in the comments so that Grace can pick it up. Also, Skyla, on the IOCDF website, there's a big, good page for books and workbooks. And so maybe if you could put that in the chat, and Grace, you can click on that. The IOCDF has some really good books. I know that a lot of my young adults really like Turtles All the Way Down. They feel like it's a really good representation of OCD and more like a fiction book. I would say for nonfiction, the ones that I really like Jeff Bell's books. I think he's written 2 books on his experience with OCD. John Grayson has a really good book, obviously, on OCD. There's the OCD workbook. I know you said Bruce Hyman, but there's another one that I have. I can't think of. I think Dr. Claiborne might have written it. But definitely click, Grace, on the link from what Skyla's going to put in, because that has a lot of really good books, and hopefully people in the chat will write it down as well. Paola already gave you some. So Freedom from Obsessive Compulsive Disorder by Grayson. That's one of them I suggest. Yeah. David says, thank you for your insight and time. Of course, David, happy to have you. So Grace asked another question at 12:13. So what is ACT in regards to OCD treatment? Still super new to what ACT is, acceptance and commitment therapy, and still trying to get a grasp of the basics that comprise this modality of treatment. So Grace, if you were in treatment a long time ago, the way that ERP was presented is it was presented in a way of, you gotta, engage into an exposure to get better. You should really push yourself. And while you're in the exposure, you're going to be anxious and you're going to want to monitor your anxiety. And eventually it's going to go over time. You're going to habituate and you're going to feel better. And so what happened is, for a lot of different people, the treatment worked, but I think the best way that I like to describe ACT, or acceptance and commitment therapy, is it's a framework. You wouldn't want to do it alone, but you'd want to use it in conjunction with ERP. And so what ACT is the acceptance component is acceptance of thoughts. I think a lot of times us with OCD, we make the mistake that we treat thoughts as if they're bad, as if they're real. We treat them as if they shouldn't exist. Acceptance is a very different mindset. It's saying, look, I'm going to choose to do less. I'm actually going to choose to take a more passive approach. So I have to just accept that having OCD means I'm going to have thoughts, intrusive thoughts. I'll say, as somebody that's now been in treatment and out of treatment for a long time, I don't have intrusive thoughts in the realm of OCD. We all have intrusive thoughts. There's been so many times on a plane when a kid is screaming and crying, I'm thinking, what if we just like open the window and push them out? Obviously, I wouldn't do that. But we all have intrusive thoughts. There's so many research and studies that show individuals without OCD have intrusive thoughts. But the OCD intrusive thoughts are just like repetitive and graphic and disturbing in nature and debilitating. I don't have those anymore around the subtypes that I had with OCD. But during the treatment, the acceptance is really saying, like, I'm going to accept its presence and I'm making a commitment to not respond to those thoughts in the way that OCD would like. So if I'm in the store and I have a thought, first of all, the mistake and what isn't acceptance is being really worked up by the thought. Why am I having the thought? This thought is so terrible. I hate this. I got to go. And then the compulsion, which isn't a commitment, right, is to bolt out of the store. But acceptance of the thought is when it comes, it's like, okay, I've noticed you're there. And part of the act is diffusion. So recognizing it's an OCD thought. This isn't something that's aligned with my values or aligned with me as a person. I don't want to harm people, but OCD is telling me I am. And I've made a commitment that I'm going to go through the store, get what's on my shopping list, and leave. So it's really, really making that commitment to live in those values, to let your goals guide you. So a lot of times in ACT, we're also figuring out your why for motivation. So for me, some of my goals and values was I really, really, really wanted to show up for my family and be there for them. And when my OCD was at its worst, I missed half of my great grandma's funeral that I was a pallbearer in because I was doing compulsions. And so that was not living by my values of somebody that wants to stand up for your family and to be there for them. So values and goals really, really drive ACT in the sense of really understanding like why you're doing this treatment, why you want to get better, and making that commitment that if I want to be there for my family, even if I'm having something happen at my house and the OCD says I have to stop what I'm doing and clean the whole house, or whatever the compulsion may be, or if I'm driving to the funeral and OCD says you need to keep going around the block, it's making that commitment that I'm going to still choose to go to that funeral, live with that doubt, that uncertainty, that discomfort, because I've made a commitment and really stand by it. And diffusing yourself. I think that's why we have people name the OCD, sometimes draw the OCD, and really put it as something that's out there, something that you experience, not something you are, so that you don't make the mistake of giving into OCD because you think it's something that you really want. So I know a lot of therapists with ACT will also use a lot of analogies. That seems to be really, really helpful. But the main important thing is I don't want people to think like, well, I'm doing ERP and not ACT. I got to go do ACT. ACT is a framework to explain ERP and to do ERP in a way that really makes people buy into it more and connect with it for motivation. So I would say the way that you know your therapist is utilizing some ACT techniques is if they're really, really having you identify, like, why are you in treatment? What are some of your goals? How does the OCD stop you from reaching the goals? Let's pick this exposure because you really want to be able to graduate and walk in graduation in a month, but you can't because of these compulsions. So let's work on that to get you to graduation. And so I think a lot of times people see that and it's a lot helpful. There's also some other good books that people have been saying. So Nikki said Overcoming OCD by Dave Veal. Wow, I read that way wrong. So that's another one. All right. So another question. Hopefully it is okay with just me alone. Like I said, I love having Liz because we can banter. So hopefully you're not sick of my voice yet. So Vishali Jain on YouTube says, when I see my real brother doing something or talking something, I always think, oh, that's why I like him, I love him, and want to marry him. Okay, so one subtype of OCD is definitely going to be intrusive thoughts around family members. So, a lot of people will use the word incest. And so part of the reason that we advocate and part of the reason that we want to get the word out about OCD is because these aren't the themes of OCD that are getting discussed in the media. These aren't the themes that are getting talked about. And so I've met so many of my clients who've had OCD and suffered for 20 years, 30 years, 40 years. And the reason for that is because they don't want to talk about this or they don't hear about this. They think that there's something wrong with them. They usually are depressed, might turn to alcohol and substance abuse. They might isolate, etc. And so it is extremely difficult to be around a family member, like in your case, your brother, and having intrusive thoughts that you might like them. That's why a lot of times we'll say, like, after you really start doing the exposures, don't want to get too caught up on content, because when you have intrusive thoughts about liking a family member, you're going to have a lot of shame, guilt, embarrassment, disgust. And those are some really powerful emotions. And so if you're having those emotions around that, sometimes it's hard to do to fight back against the OCD because it feels just so real and so intense. So a lot of times I've had clients that said they've moved away from home. They block their brother on social media. They won't look them in the eye, all these different things. So going back to Grace's question about values, if I had a client like you, Vishali, the first thing I'd want to figure out is like, why is it important for you to reconnect with your brother? Because we got to have a reason that's more powerful than the OCD. And so typically somebody will say, I really like this family member. They're one of my favorite family members, but I've been completely avoiding them like the plague because of the reason that I don't want to have these intrusive thoughts. And so the problem is the more you avoid the family member, the more these thoughts are going to come around. And so once we've identified that we want to push back against this intrusive thought because we want to spend time with our family member, what we'd then do is we'd start to kind of like pick exposures that are rational and make sense. So let's say one of the easier things for you is to make eye contact with your brother. You'd start just working on making eye contact with him. So when OCD typically would want you to kind of look down or look away, you would practice like making eye contact with your brother. Now, what that may bring on is some intrusive thoughts and some feelings. And the mistake that we make with OCD is we immediately try to push them away or we freak out about those thoughts and feelings. We start to identify them for what they are. It's the overactive part of my brain telling me something's wrong when there's really not. I need to teach it that everything's okay here. So I'm going to make that eye contact with my brother, and then I'm not going to run in my room. I'm not going to check my groinal response. I'm not going to ask a family member. I'm not going to research anything on the internet. After I hang out with my brother, make that eye contact because that's the first exposure we've decided to do. I have other things to do that day. I have to go run errands. I have to go to class, and I'm not going to shift the rest of my day simply because of my exposure. I'm teaching my brain that I can have anxiety with me and still function, and then you'd work up to it. But I do want to just say, like, it is difficult when you have these intrusive thoughts around hurting kids, having sex with kids, having intrusive thoughts about family members. And what I know, because I know OCD and have it and know the community, it's the furthest from the truth. That's what you don't want. And so don't make the mistake of spending every day trying to prove to your brain, prove to the OCD that you don't like your brother, because it's just going to make you more confused and it's just going to get you more consumed in it. So hopefully that helps. I'm going to go really quick to a pre-submitted question. The first one is, what are the first step treatment options for clients with severe OCD? So we have something called the Y box. It's the Yale Brown Obsessive Compulsive Scale. It is a 10-question measure to kind of see the severity of OCD. So let's say you take that. The IOCDF has it on their website, so you can self-take it, or you can, some treatment centers like Gateway, where I work in Costa Mesa, we do a free assessment so people can get their Y box done by a professional for free. And that is going to tell you your severity levels of OCD. So how severe is it? Let's say it's pretty severe. It's severe or extreme. What I typically suggest is that you look for an intensive outpatient program, a partial hospital program, or potentially a residential if it's extremely severe. And the reason I say that is because if it's severe to the point that you can't work, you're rarely leaving your house, you're not able to do some basic functioning at times, your life is just consumed by it, and you're not really able to function without the help of others, no school, kind of isolation, going to see a therapist once or even twice a week. There's so many hours you're not there, and you may get to a point where it's like there's too much kind of piling into your shopping cart and you're taking too little out with your therapist. An intensive outpatient program is where you're going to be at a treatment center. Ours is, one-on-one with a therapist for 3 hours a day. I know Rogers, I know Renewed Freedom. I know a lot of different treatment centers do it different. It might be 3 hours, 4 hours. It might be 3 times a week or 5 days a week. But you're going to be spending a lot of hours during the week working with your clinician and then having homework after. Let's say you're more severe. I know Rogers in the area has a partial hospital program. So that's going to be 6 hours a day that you are in treatment with a therapist. So you're really, really working on that for 6 hours a day. And then someone who's extremely severe, they're going to get into a point where they're going to be inpatient. So that means that you're kind of living and eating and kind of sleeping at a treatment center. And that's going to be for someone that's extremely, extremely severe who can barely function. Let's say none of those is an option. Let's just say that it's not. And you're just unable to, go to that kind of level, let's say because of cost or insurance coverage or distance, then what I'd strongly suggest is seeing an OCD specialist. Once again, like we announced at the beginning, I'd go to iocf.org/find-help, put in your zip code. You're going to find an OCD specialist in your area. So that would be my first suggestion, is find somebody that really, really, really knows this disorder. I only see clients with OCD, BDD, and related disorders. You don't want to see someone that also sees couples for marriage and who sees people who are struggling with work if you're severe. Some therapists have training from the BTTI, from the IOSDF, and they do treat OCD and they treat a lot of other things. It's not a bad thing per se. But if you're severe, like the question asks, I mean, you want somebody that really, really knows this OCD treatment and can work with you. And you may ask them to work 2 or 3 times a week to really get started in momentum. You always want to find someone that works with exposure and response prevention. There's a question about ACT, there's questions about CBT and all these other things. They could be used as adjunct, but exposure and response prevention is what we call evidence-based treatment, meaning that it's been studied and studied and studied in different research modalities, and really comes back that when people use ERP, they find themselves getting better and a reduction in symptoms. So making sure that you find someone with that. And then on top of it, come to live streams like this, come to conferences like the one in July or the virtual one in November. Just immerse yourself in this community, self-help books, workbooks, coming to affiliate events. And that's going to help build a community, find a support group while you're going through that more severe treatment. So Yvonne says that you're suffering greatly from contamination, OCD, and depression due to loss of your parents. Listening brings you comfort. We are so, so happy to have you. Thank you so much. The next question is from Julia. I'm sure your name is Julia, but it just sounds better when it's a Julia. I don't know if that's French or what I'm making up right there, but Julia, Christine, what a pretty name, from 1216. And it says, I'm doing ERP. I just started, but I didn't even hit my smallest goal. My OCD is around my health, cancer specifically, and terminal illness. That was one of my worst subtypes, Julia, so I totally feel you. I can't get over the uncertainty of potentially dying. This has been going on for 15 years. I feel like I'm failing at ERP. So what I would say first and foremost is the only way that you fail at treatment is if you choose not to do it at all. Please don't be harsh on yourself. Think of treatment as learning a language. It's not meant to be this like quick fix bandage. That's why a lot of times when people will go to a therapist that doesn't really know OCD treatment, and they'll teach you like deep breathing or calm and stuff like that. That's just like a Band-Aid on a dam. It's not going to work for OCD. So the treatment is really kind of learning how to live differently, to treat your thoughts different, to challenge your thoughts differently, to change your behaviors, to move towards things that may feel difficult momentarily, to really build up a lifestyle. And in order to do that, it's like learning a language. It's a process. So don't get mad at yourself if you're not, doing it correctly, or if it's taking a lot of time. I promise you're not failing. It's also going to be up and down. I mean, even in my own treatment, I wasn't this like exemplary, person in therapy. Like I had my ups and downs, and I had those moments that went really, really well. And I had those moments that I struggled a little bit, but I kept my eye on my prize and leaned on my support and my mom to keep me on track. What I would say, and what I do with my own clients, Juliet, first of all, let me take a step back. I had the same OCD subtype. And what's really difficult is you start to get to that feeling that cancer is caused by everything. I started questioning what I was drinking, what I was eating, the air I was breathing, what I was doing. I was putting on like those Brita filters on every sink on the shower head so that it would filter the water. I would hold my breath when I was outside till I got into a store because I was like, oh my God, the air outside is polluted. I was constantly researching cancer. Anything that was a bump or something, I would go to a doctor's appointment. I didn't want to be around people smoking or alcohol or anything that I read could cause cancer. I was dropping food groups left and right, things like that. Always looking at where products were from. They had to be from an area that I felt was safe and not had cancer in the product. So it can be exhaustive because there is reality there. What you want to learn, though, is even though cancer and health is real, your brain is giving you an overestimation of danger. So think of the parts of your brain that censor danger. They're called the amygdala. They're these 2 little almond sizes in your brain. They're overactive. They're kind of like the boy that cries wolf. So every little thing, it's like picking up a phone to your main brain and saying, Julia's in danger, cancer, cancer, cancer. And then you freak out and give into it. So part of the treatment is to really recognize that the OCD brain is kind of like building this world where you are constantly getting cancer and you're always going to get sick. And if we buy into that world and live in it, we're going to be doing compulsions every day. When we instead learn like OCD is a disorder that is giving me false thoughts and exaggerating concerns to the point that it feels like I'm constantly in danger, I can respond to that differently. And that's where the ERP comes in. So an example could be, for instance, that when it comes to, like in my own case, like when it came to researching or looking something up, it was choosing not to engage in that right away. So what I mean by that is, oh, there we go. The question moved for a second. Sorry. So what delaying really helped me. So an example would be if I had like a bump or something and I would normally like make an emergency appointment or go to urgent care. What I would do instead is I'd say, okay, I'm going to call, but I'm going to make an appointment for 2 weeks. I will call them back and make a more urgent appointment if the little bump gets bigger or something. But I'm going to make the appointment for 2 weeks, because the big mistake I always make is I act on it right away. And what would happen is I'd make that appointment for 2 weeks. 2 weeks would go by, and then it would be gone and I'd be over it and I'd cancel the appointment. So one thing you could try, Julia, is to make a smaller goal and to delay. Maybe you can't completely not give in, but you can delay it for a little bit. So somebody that wants to wash their hands or drive back around the block, maybe instead of doing it right away, you set a timer for 5 minutes and then do it. So when I have a client in your position, Julia, that's really feeling frustrated, like they're failing, I go smaller. I'm like, look, the point of treatment is to learn from this exposure. And if you're feeling overwhelmed and like you're failing, you're not going to learn. So let's shrink it down. Let's go a little bit slower. Let's go a little bit tinier. Let's maybe, instead of giving it up, let's delay a little bit. And then when people start doing well and build success, that builds up momentum, and then they do well. So hopefully that helps. I see a lot of really good book examples. So hopefully people are looking at those. Leanne says, yes, identify why you want to do that exposure. Absolutely super, super important. All right, so Ed at 1217 says, I'd major surgery about a year ago, and afterwards my OCD virtually disappeared after 40 years of suffering. It has slowly returned. By the months of relief were really remarkable. Have you ever heard that from anyone else? I'm trying to determine if the relief was given of the strong painkillers I was given after surgery as a result of the trauma of surgery or something else. So I'm glad that you put the second part in there. So the only time, Ed, that I've heard about this, for two reasons, is one, the painkillers. I had a client, same thing. They got in a car accident and really, really injured a part of their body and had to be on heavy painkillers. And they said that their OCD was almost kind of gone. But to be honest, it wasn't because painkillers make OCD go away. They were so just numbed out to the point that they just weren't having really intrusive thoughts, but they couldn't work. They were in bed a lot of the time. So obviously, unfortunately, being on high painkillers is not going to be a way of life. The second thing, though, what I hear more often is when somebody has like a real tragedy in their life. They just got in a horrible car accident and are getting major surgeries. A family member just died. Obviously, for a lot of people, that can exacerbate the OCD and make it worse. But for some people, when they're going through like a real disaster, the brain almost puts OCD on pause. For some, not all, but puts it on pause because you're focusing with a real thing. So I had a client that got cancer. That wasn't their OCD. They got cancer and they really stopped caring about their OCD intrusive thoughts. They just didn't care because they had something bigger that they were focusing on. So those are the two times that I've heard of this in my own personal experience. I don't know if this is something that a lot of people have heard of or if it's something being studied, but I had a client on heavy pain medicine, and once they got off of it, it slowly started to come back. The other reason was because the pain medicine was keeping them in bed a lot. They weren't like functioning, so they couldn't do their compulsions. So because they couldn't do compulsions while on the medication, they're on it for a long period of time because they're really injured. So what I taught this client and what I teach you, Ed, is while you're on this medicine and you're focusing on recovery from your surgery, you probably weren't doing compulsions. And when we stop doing our compulsions, the OCD starts to fade. We always falsely think that the compulsions is what's keeping us safe and making us feel better. No. The compulsions are what's keeping the OCD to keep coming back and coming back and coming back. So if you're injured, if you're going through a real big life event, if you're on medication like that, whatever, and you can't do your compulsions, the OCD is going to start fade. And as it slowly comes back, if you make the mistake of giving back into the compulsions, that's when you're definitely going to start to see it come back. George says, hi, he's new here, so great. Skylar just put up a book directory, so iocdf.org. /books/ So please go to that and look at different books. Love Lana on YouTube says Kim Quinlan. She has a great book as well. So hopefully those books, Patrick McGrath, I don't know his book, but duh, I know his book. Don't Try Harder, Try Smarter. So definitely a really good book and a good presentation. I think he does it at the conference and stuff like that. We have Saraba from India who says they've been suffering since 1997. They are sharing their experience to help people with OCD. So that's why I love this community and the comments in the chat, because it's really, really letting people know that you can get better and there's a community out there. So Yvonne says that I struck a chord with you. You're stuck upstairs in your house and feel horrible going downstairs. So yeah, hopefully the example I was giving was helpful for Nikki as well. There's a lot more good books. So yeah, please check the comments. There's a lot of really, really good books there. All right, so Tiago at 1223 says, I'm from Portugal. I have sexual orientation OCD. The usual approach to treat OCD is how to deal with the thoughts, but is it worth understanding where it comes from? So like a difficult childhood, toxic relationships, real denial. So what I would say the community consensus is OCD is a very hereditary disorder. It's very biological. So, in the DSM, which really talks about the different mental health conditions, it talks about, if you have a family member, a close family member that has OCD, you are much more likely to have OCD. I think it's 10% if they developed OCD in adulthood, something like 40% if they had it in childhood. So it's very, very highly passed down. So that's why when you start to look at family members, it's like, wait, do they have OCD as well? So for a lot of people, it just appears through those puberty moments in life. So like 8 to 13 or like 18 to 21 when puberty stops, or perinatal OCD when they're pregnant and the hormones are changing. For a lot of people, there is no like deep reason that they have OCD. Sometimes the OCD gives you secondary gains. So an example is some people have OCD, go through a hard trauma, and then the OCD is like so demanding and they're so fixated on their compulsions and their intrusive thoughts that they're unable to really focus on the trauma. It kind of distracts from them, but nobody would just like not have OCD and get it from trauma. Sometimes people have minor OCD and then a major event happens and they feel like the dam broke and their OCD comes out pretty extreme. I had a friend like that when he got in a car accident. But right now there's no evidence or anything that comes up, and it needs to be further studied if there's something that it stems from. Part of the reason that I have never thought that it's something that, a life experience is because when you talk to a room full of people with OCD, it's not like everybody comes together and says, oh, I had that difficult childhood. There's people that had great childhood or toxic relationships. Sometimes if somebody has a theme, like let's say sexual orientation OCD, like if you grew up in an extremely conservative family that has really negative things to say about the LGBTQ community, which hopefully they don't, it's Pride Month. But if they do, sometimes that can add an extra layer of anxiety and distress because of just reality, like your family, the fear that my family would disown me. They would think I was terrible. They would talk to my church. They would bring up conversion therapy. So sometimes when it has a real family, background like that, that may contribute to it. It doesn't cause it, but may contribute to it. So hopefully that helps. I always tell people it's better to spend more time on getting better from the OC than trying to figure out where it's coming from, because researchers are trying to do that and we don't have the answers. Leanne at 1224 says, when you have OCD, you may experience false memories that feel like real experiences. Would this apply to all subtypes? And how do you distinguish between real and fake memories? I would say we see that the most. Actually, come back next week. So next week on June 22nd, Patrick McGrath, so Dr. Patrick McGrath is our guest. I think it's just going to be me and Patrick. I think it's just going to be us two. But we're going to do a whole special lunch and learn on real event OCD and false memory OCD. So I'm not going to get too much into it, Leanne. Not that your question isn't valuable. It's extremely valuable. But we're going to spend a whole hour on that next Wednesday. So come back. But one of the ways that you distinguish is you stop mentally checking. So the mistake, and we'll talk about it next week, is if people are trying to remember a past memory, they're trying to ruminate, they're trying to figure out, they're trying to check that past memory. It makes you more confused. It's like making a photocopy of a photocopy of a photocopy of a photocopy. It starts to become super blurred. And so then it is really hard to determine if it's real or not. And then OCD starts to put in its own version of events. And the next thing you know, you are really confused. So the treatment is to stop trying to check that old memory. It's saying, look, I don't know if that memory is real or false, and I'm not going to act on it. Instead, I'm going to keep moving forward despite whatever that false memory is. What happens is when you move forward and you disperse from the compulsions, that's when the clarity starts to seep in. And then you're like, oh, of course I didn't hit somebody with my car 6 years ago. I would know that. But you can't get that clarity if you're doing compulsions. But please come back, because like I said, we're going to spend a whole hour. So that's why I'm skipping through it. People are saying they're not sick of my voice, and thank you for advocating. I really, really appreciate that. That means a lot. Gentile has a second question at 12:27 and says, is it normal to have way less energy after developing OCD? OCD is exhaustive. If you've ever seen the brain scans of an individual with OCD, our brains are lit up. It is going to drain us daily to have so many intrusive thoughts, so much compulsive rumination, avoidance, compulsions. It is so exhausting. We often develop depression. Depression drains us from energy. So even if you don't have depression, having OCD drains us. And so what I always see is once somebody's getting better, they feel like they have so much more free time, so much more energy. So if you are stuck on why to get better and why to do treatment, I promise you this is an example of why you're going to get so much energy. I promise that. So definitely make sure on that. At 12:28, Lorena says, an exposure left me with so much shame and guilt. How can we move over something like that? It's hard for me to answer directly just because I don't know what the exposure was, but I would definitely say that shame and guilt is a huge part of having OCD. In fact, I'm doing a talk at the virtual conference with Kim Quinlan, Allegra Caston, and Jessica Serber on shame and OCD. So hopefully you can make it. We're doing a second talk on the emotional toll, so discussing guilt and other emotions. What I learned to do is to separate myself from those feelings. Feelings are temporary, right? Like, my birthday was May 26th. I'm not still like on cloud nine from my birthday. Like, it was great, my birthday, and it's kind of faded. It's other people's birthdays now. I almost forgot about it. We recognize that emotions are temporary. So experiencing shame and guilt is a temporary experience. It's a temporary feeling. So we know that that's going to pass. The problem with OCD is we don't let emotion pass. We kind of grab them and like bash our heads over, and it's like, why? And that just keeps it around longer. So if you did an exposure, specifically one guided by a therapist who you really trust, my guess is that you didn't do anything wrong. But because you're challenging the OCD and doing something different than you've always done, OCD is going to tell you that. So if let's say I have intrusive thoughts that I'm going to shout something horrible out, racist or provocative out in public, and I go out in public and I stay there for hours, something I've never done, and I interact with people of different ethnicities and races, which I never do because of my OCD fear, and go home, and then I feel like, did I say something? Oh my God. I'm going to feel some guilt. And especially if I do response prevention and don't do any compulsions, I'm going to feel super guilty. But what I'm going to recognize is that's just OCD playing with me. It's trying to get me to feel shame and guilt because I'm finally standing up for myself and fighting back. So don't let yourself attach and hold on to shame and guilt that you don't deserve, right? That's the OCD. That's why diffusing yourself, naming it, it's like, that's OCD. That's OCD there. So definitely don't let yourself own that, because we're going to feel shame and guilt and irresponsibility when we stop doing our compulsions, because we've taught ourselves for so long that the compulsions are what keeps us safe. And so when you do something against it, it's like, oh, you went on a date with this girl because of relationship OCD and you used her. You're such a bad person. I mean, it's going to try to make you feel terrible. So don't let it get under your skin. It's a temporary experience that will fade on its own. All right, so we have Indonesia. This is great. We have a lot of different people from all over, so it's so good to hear from everybody. Katie Jeffrey says at 12:47, has there been any valid research regarding curcumin supplements to help with OCD? So if you do want to do this, Katie, what I would strongly suggest is going back to our recent, I think it was the beginning of the month. I don't think it was last week because that was Research Roundtable, but 2 weeks ago, we did a live stream with a psychiatrist, and people asked about research around supplements. And what the psychiatrist said is that as of right now, there is not any supplements that have been found to help with OCD. Now, somebody put this in the chat. So if you could put up 1242 NAC, what I have heard about that's from Likeable Llama at 1242. There is research that NAC has helped with BFRB, so that's skin picking, hair pulling. It's a supplement you can just get at like Whole Foods or at a grocery store. It's an over-the-counter supplement. And there is some research. You can go to, I think it's on the BFRB website. I want to say TLC, but I don't think that's what it is. But there's a nonprofit that specifically focuses on BFRBs, and they've published research that NAC, which is like an enzyme, can help reduce with skin picking, hair pulling, and those other OCD-related disorders. It hasn't shown to be as helpful with like OCD. But to go back to the original question, go to our live stream from 2 weeks ago. The psychiatrist talks about it. From what she said, there's no research that says that those supplement help. So I would definitely go back to it though, and just definitely make sure that you look at it and kind of get the words from herself. At 1237, we have a question from Danielle that says, my 14-year-old daughter has a rapid onset of OCD after a Lyme-PANS diagnosis. Can ERP with OCD help with OCD caused by brain inflammation? So Susan Boaz, who is the IOCF president, also works with the Pandas Physicians Network, so the PPN. I believe the website is ppn.org. I would definitely go to that website for more information. What's different about OCD brought on by PANS is that there's different things that you're going to have to do medically to help with the infection in the brain from the Lyme. So I know like some people with PANS and PANDAS will go on different like antibiotic regimens, which obviously you wouldn't go on for OCD. What I've always been told by all the experts that really understand and study PANS is that once that gets dealt with, they still are going to have OCD. So ERP is definitely helpful. Just like an individual that needs medication, it is going to be much more helpful if you're treating the inflammation first. And maybe starting to work some ERP in there, mainly starting with psychoeducation to get an understanding so your 14-year-old daughter understands what's going on, because she may not be ready to do ERP if she has no clue what is even going on. So that might need to happen first, is to kind of, to understand what's going on first. But yes, there's still going to be symptoms. So I've worked with plenty of clients that have PANS. And they've gone through and gotten the medical attention, and then they still have OCD. So typically what I find in more clients with PANS diagnosis is it's a lot more like repetitive behaviors, kind of tick-like movements and stuff like that. So the behavioral treatment is still needed if they have PANS. But go to the PANS Physicians Network, PPN. It's going to be helpful. Zadie at 1236 says that your son has avoided going to residential for months after being in one for 6 months and doing an IOP several times and not working on exposures. He's not doing good, but at the same time is not willing to do it. Should we keep waiting until he's ready? He's 15 and he started when he had 13. Is it because of his age? A lot of people with OCD need a why to get better. If you are high up in your company, you have a family, you have kids, you have a why. You don't want to lose your marriage. You don't want to get, fired from your job. You have kids to think about. So a lot of times I work a lot with teens and young adults. A lot of time a 13 or a 15-year-old just wants to be normal. They want to be left alone. They think they can figure out the OCD on themselves. They feel like they're trying to be fixed and nagged, and they're very resistant. I always tell people, I started getting treatment at 22. I have no clue if I would have been open to treatment when I was 15. I definitely think that you want to figure out what is his reason. So like when I work with clients, I ask them, I'm not their parents, I ask them, why do you hate OCD? Why are you so tired of this disorder? And if the disorder just magically went away tomorrow, what would be better in your life? Let's say the kid says, I love basketball and I'm so tired of intrusive thoughts when I'm practicing, counting my steps, ruminating about the game. That's what I'm going to focus on. I'm not going to worry about the fact that he takes a 3-hour shower and drives up your water bill, because your son might not care. I'm going to focus on what does he really want to get back. And I'm not going to make the treatment about everything else yet. Let's just get you back into basketball and make it easy. Once the ERP works for that and he sees value in it, he's going to be much more open to focusing on the other stuff. The other thing that you want to be careful about is if he's at a residential or an IOP that doesn't do any kind of behavioral work. This is a behavioral disorder. If I'm picking up my phone and setting it down 12 times a day till it feels right, talking to someone, yes, cognitive behavioral therapy, psychoeducation, understanding the disorder is super helpful, medication. But at the end of the day, I have to face the behavioral component. So if your son wasn't actively challenging the OCD, then he might have been. We have plenty of IOPs around here through hospitals that are just like a general anxiety and depression one, not helpful for clients with OCD because they never did anything. They talked a lot, they did breathing, they did stuff like that that's helpful for depression or anxiety, but nothing for the OCD. So making sure that your son was actively doing stuff. If he was, let's say he was working with people, it sounds like it wasn't because it says that he wasn't working on exposures. But let's say he did do that, like he went to a residential and IOP and it was really good, recommended. There was ERP, there's behavioral work, they understood the OCD, but he's still not willing to do it. I guarantee if you can tie it into something he cares about, that can be helpful. Make it a family thing. Setting time aside for 45 minutes a day, we'll kind of be in the room with you to support you while you do ERP until you're ready to do it alone, and just setting some time. So putting it in their schedule. A lot of teens have very consistent schedules, and that might be helpful. Feel free to email me. There's a lot of really good, email maybe the foundation. So if you email info@iocdf.org, and you could just put Chris in the headline. There's a lot of really good advocates. I help oversee on the clinician end the young adult advocates. And so sometimes connecting with one of our advocates that's around his age might really booster his motivation. So please reach out, put my name in that. And that way we can hopefully get him with somebody that would be helpful to kind of, make him feel confident that the treatment works and helps out as well. Dylan says that this has been helpful to listen to. We really appreciate having you. Patricia's giving advice in the chat, so I really am helpful for everybody like that. Valencia at 1256 says, what can I do because I have OCD health related to talk to my medical doctor about real health concerns as a result of my OCD? It seems it is thought as I am making too much out of my illness. Yeah, so the challenge starts to become if people around you know that you have OCD around health stuff, it starts to become one of those things where it is a little bit difficult, because we want to get to that point of not treating everything like it's a health concern, but then people get frustrated because if they have a real health concern, then they're like, well, great, now nobody's taking it seriously. So what I tell my clients with health OCD is when you show up to the doctor, present the information and then zip it and let the doctor really do their work. They're going to ask you more questions if they want clarity on things. Because what my clients will do is they'll go in because they've done online research and almost trying to coax something out of it. Like, oh, I have pain and I know it's my kidney because the pain is right where the kidney is. And I just know it's hurt. It's my kidney. Well, now you're kind of directing the doctor. And so they might start the labs and stuff on your kidney, and that might not even be the problem. So I had terrible health OCD. One of the things that helped is not making quick appointments or rushing to a urgent care. Instead, making an appointment a couple weeks out and only expediting it if I was in pain. And then when I get to the doctors, I would just report my symptoms. I'd let them do their work and I'd go home and I wouldn't do more or less from what they gave me. And pretty soon when the OCD went down, because I wasn't doing that extra compulsions, I got a lot more clarity if something was OCD or if it was absolutely a real health condition. So you don't need to not go to doctors or take care of your health simply because you have health concerns. But if you're going to different doctors all the time, calling all the time, emailing, getting tests and researching, you're going to create this kind of world that you live in where you're constantly this close to dying and you got to find the cure to keep yourself safe. Let the doctors, you're going to a specialist for a reason. Let them do their work and don't do too much or too little compared to that. All right, I think I caught up on the live questions. I didn't get to all of the Ask the Experts pre-submitted questions. Sometimes it's hard for me because I have to go to a different screen and then I do that. One of the questions is about TMS, which I think would be good to save for another time we have a psychiatrist on. So if you ask the question about transcranial magnetic stimulation, yes, it is definitely something that people are using. Make sure you get the OCD coil, but we'll have a psychiatrist on there to talk a little bit more about that. There's two questions then that I didn't get to, so I'll make sure to get it to the next one. I feel like I talked a lot, so hopefully you aren't sick of my voice. I want to first and foremost thank everybody for joining us at the live stream today. I hope that I was able to get you some direction and just get you some information. Please go to iocdf.org. Everything I talked about today, there's much more resources at the International OCD Foundation's official website. So you can look at that Find Help resource and find a clinician near you. And you can go to them and say, look, I talked to this guy online who's an advocate and a clinician with the IOCDF. He gave me this direction, and just kind of get started on treatment. That's the main thing that you want to make sure you do. So go to iocdf.org for more information. We are here every Wednesday at 9 a.m. Pacific Standard Time, noon Eastern, and I'm so bad on wherever else you're at with time. It's already hard for me to do the 3 hours ahead. So wherever you're at, it's the same time every Wednesday. So Liz and I do this Ask the Experts, where we answer your pre-submitted and live questions every first and third Wednesday of the month, sometimes the fifth if there's an extra Wednesday. The last Wednesday of the month, which is next week, make sure to come back, because on June 22nd, Dr. Patrick McGrath from NoCD and I will be answering your questions. We're going to start talking about real event OCD and false memory OCD, but we're going to also transition into answering general questions. So come with your questions. We'll make sure to get to those submitted questions as well. Don't forget, it is tomorrow. There is a special live stream. So Alexandra Reynolds, who is an amazing IOCDF advocate, is going to be joined by myself and Justine de Jaeger for a special edition Pride Month live stream. So the topic will be on being LGBTQ in the OCD community. So you can submit questions ahead of time on social media. So go to IOCDF's social media or online at iocdf.org/peace of mind. Somebody asked if you have to be LGBT to come. No, we're going to talk about OCD. So come. So make sure you're there. Lastly, I'm going to say the most important thing: if you can, please join us for the first in-person conference in a couple years. So it's the 27th annual OCD conference. That's going to be in Denver in July. I'm going to be there. Ethan, Liz, all the advocates. It's going to be so much fun. I'm doing presentations and hanging out. It'll be good to meet all of you in person if you can make it. So it's for everybody in the community: therapists, family members, supporters, kids, etc. So make sure to go to iocdf.org/OCDCon. Thank you so much for joining me today. It was really appreciative to have so much support and so much interaction in the comments. I read every single one of them. They're sweet. I really appreciate it. We will be back tomorrow for the LGBTQ edition. Come back next Wednesday at the same time, 12 noon Eastern, for Dr. McGrath and I on real event and false memory OCD, and we'll answer other questions. And hang out with us all month long. We'll see you at the conference next month. Have a great rest of your day. And I promise you, as somebody that's gotten better from OCD, if you do the treatment and you fight it, you will absolutely get better. And it's the same time. Somebody asked what time is the live stream tomorrow. It's the same time, 9 a.m. Pacific, 12 Eastern. So that's what I want to leave you with. As somebody that fought OCD and got better, you can get better with treatment. I promise you. Just stick it out. Remember, it's a process. It's like learning a language, but you will get better. Take care and have an amazing rest of your day. And go to iocdf.org for all of your OCD support.